Thank you, Ms. Manish Bhai. And first of all, I'd like to thank all the organizers for this opportunity. We'll not only be discussing about relays, but it is important to realize, which is probably the crux of the lecture, that EGFR is not a single disease. So it is now at least 18, 19, 20, 21. We have 4 diseases which need to be tackled differently. So can somebody share the slides? Yeah, you can make it. Yeah. Next. Next slide. So these are the disclaimers. Next. Yeah, you can move on to the main slide. So basic question is, there are a few questions which need to be addressed. One is whether EGFR is a single disease which we used to, which we like to treat. So you like to give Geftinib and osimertinib to everybody. Once you see EGFR, you are really happy. A patient has landed up with a EGFR mutation, but it's not a single disease. And so the question is whether we need information. You need just the information that a patient has a EGFR mutation, or you need a lot of other things to realize what should be done with this patient. Next slide. So let us start with a case, a typical case. She's a female non-smoker, stage 4 adenoCA lung, has comorbidities in the form of diabetes and typical symptoms of cough, dyspnea, weight loss. So the next question would be, next slide. Question would be, what do you do? So basically, you got the biopsy as adenoCA. I think our previous speakers are already discussed, and some discussion was going on previously also. So 2 things are important. One is whether you do a targeted mutation in the form of your EGFR cross, or you send an entire NGS. So the debate continues, but probably you'll see a few slides towards the end why NGS is more important than just predicting whether the patient is EGFR positive or not. And again, whether a brain MRI should be done prophylactically in every patient, or whether you should do it in patients who are symptomatic. So we know that it should be done if the patient has symptoms. We don't do it prophylactically as far as NSCLC goes. And obviously, patient and NGS was sent. Next. So since the NGS came out to be EGFR positive, and it was L858 mutation, which is exon 21 mutation, it is pathogenic, it's a driver mutation. Next. So then, as I was previously alluding to, whether you are looking at patient as a deletion 19 or an L858 21, these are the 2 most common. So majority, let's say about more than 90% of the patients have either of these 2. The others 18, 20 make up like hardly 2-3% of the mutations each. So point is whether you treat both of them the same way, or it is time that you differentiate between the 2 and you treat them according to their merits, and as well as other information that might come with these mutations as well. So next slide. Go to the next slide. So this is the entire spectrum. It's a common slide. We have all seen this. EGFR, you can see from 18, 19, 20, 21. So you can see the L858 is about 41%. Previous slide, please. Can you go to the previous slide? So you can see the common ones. Next slide.
Okay, sir.
I think I should take the control. Yeah, this one, please. So, so forget it. So basically what I was alluding to is that 19 and 21 are the most common.
Share your remote control, sir.
Can you hear me?
Dr. Abhishek, you are audible.
Yeah, so somebody's talking, so there was some noise in the background. So we are looking at main issues.
Yes, sir, I can hear you.
Yeah, so 19 and 21 make up the major crunch of it. And the other rare mutations is 18 and 20, which again, all these mutations need to be probably looked at differently. So the question is, what do you, this is EGFR all that you want to know, or which mutations are involved, or which co-mutations are involved with that? Next slide. So this, I can't see the slides. Yeah, next slide. So next slide, yeah, go ahead. So what is important is, first of all, we need to differentiate that 19 is not the same as 21. So we like to treat everybody with an osimertinib or a geftinib. So there is clear enough data to suggest, this is a meta-analysis from 6 studies, more than 1300 patients, to suggest that EGFR 19 mutation is better than EGFR 21. Next slide, go ahead. So you can see, if you are seeing a patient of 19, significantly reduced risk of disease progression compared to your 21 L858. Next. And again, this is another meta-analysis suggesting the same thing. These are 7 studies and about 600 patients suggesting. Next slide. Go ahead. Yeah, so there's a significantly reduced risk of disease progression in 19 compared to your 21. So we all know that. Next. What is important is co-mutation. So this is a Chinese study which I put up, about 60 cases. And what it suggests is that you can see from the left-hand side, the green bar is your L85821. The number of co-mutations is much higher in exon 21 compared to your exon 19 mutation. And once the co-mutations are higher, you can see from the 2 graphs that the progression-free survival as well as the overall survival in patients who did not have a co-mutation, it was better rather than in the patients who had a co-mutation, suggesting to the fact which I was talking to, not just L858, even the other information which is picked up by NGS is important, because the number of co-mutations also affects your PFS and OS. And the other fact is that 21 has more co-mutations than deletion 15, probably one reason why 19 is doing better than 21. Next. Highlighting the same fact. So these figures will tell you the same thing. The tumor mutation burden in 19 is much lower than in 21 L858. Next. So then the question is, what are the options do we have? So we have the first generation, the second generation, and the third generation TKIs. What we have different recently in the last year or so, in 2021, we had the relay trial suggesting that a TKI with a VEGF inhibitor like a ramucirumab gave you equally good results in both 19 mutation as well as exon 21 L858 mutations. Next. So you can move on. So this is data across all the first, second, and third generation EGFR TKIs. And this is all the data we have as of today, major trials suggesting that a first generation TKI, the second generation TKI, and the third generation TKI, obviously it is better than chemotherapy. We know that. And the first generation have a median PFS of around 9 to 12 months. The second generation had a median PFS of about 11, 12, 14 months. And the third generation had a median PFS of about 18 months. Again, this is the first generation trials, next, second generation, and the third generation. Next. So what about the 2 combinations? You have a combination of chemo with a TKI, and you have a combination of a VEGF inhibitor in the form of bevacizumab or ramucirumab with a TKI, again suggesting the same thing. So chemo with a TKI, you had a median PFS of about 16 to 20 months in a couple of trials, and VEGF with a TKI, you had a median PFS of about 16 to 19 months. Next. An important, see, this is the most important slide, again highlighting the same fact. So this is your third generation TKI, the first part Flora, second generation TKI, as well as the first generation TKI, and the last part of it is decometinib, the Archer study. So what this slide shows you is in exon 19, you can see the PFS, all of them are doing better. So the PFS in Flora for the exon 19 was 20.4 months compared to your L858 where it was only 14 months. Similarly, in your afatinib, it was 13.8 months compared to 10.8 months for the exon 21. And you land up with your erlotinib, it is 11 months in the 19 compared to 8.4 months in your exon 21 L858. Decometinib, it was 16.5 months PFS in the exon 19 deletion compared to 12.3 months in the exon 21 mutation, suggesting that, to summarize it, if I have to say, most of these trials, exon 21, the median PFS was anywhere from 12 to 14 months, not more than that. Exon 19, they had a beautiful survival from 16 to 24 months in the Flora study. Next. So what do you have anything else which can make a difference? So then comes the relay study where we added Cyramza to this TKI. Next. First of all, you need to realize why the entire concept came from. So preclinically, it is shown that EGFR mutant tumors are more VEGF dependent and the VEGFR wild type. So a dual VEGF and EGFR pathway blockades definitely enhances the efficacy. EGFR mutations result in upregulation of the VEGF as well as the HIF1. And you can see that in the mouse models. And EGFR inhibition itself lowers the VEGF levels via the HIF1 dependent pathways as well as independent mechanism. So basically, even mutation or resistance to EGFR leads to upregulation of VEGF pathways. So makes sense. So it is one of the pathways involved in an EGFR mutant guy, and blocking both definitely adds to the response. Next slide. So this was the earliest, the beta study, which suggested, so you can see the EGFR wild type, this was using bevacizumab with erlotinib compared to just erlotinib alone in EGFR mutant patients. And what they picked up is that in the EGFR mutant guys, you can see the HR is 0.44 compared to your wild type guys where it is 0.97. So the only patients who were doing better were the EGFR mutant guys. Next. Again, this is the summary of most of the studies you can find with an EGFR together with the bevacizumab, or the first generation you had VEGF inhibitors. So you can see this is second line, first line studies. Median PFS was anywhere from 9 to 13 months, and in the single TKI arm, adding bevacizumab resulted in the PFS from anywhere to 16 to 17 months. So definitely the HR improved, the PFS improved by addition of a VEGF inhibitor. Next. Again, highlighting the same fact which I told you previously, that there are models, mouse models, as well as plasma studies showing you that the VEGF levels are higher in these patients, and inhibit definitely at the time when the resistance develops to a TKI, and adding a VEGF inhibitor makes sense. Next. Another rationale for doing this combination is once you have used a VEGF with a TKI, so as in the case with a single agent TKI, you ultimately land up into a T79M mutation. So about half of the patients would have a T79 mutations if you have treated them with erlotinib with a ramucirumab. Similarly, the T79 mutations would be about half of the patients would land up post even single agent TKI. So you still have an option of using osimertinib in these guys post your first line combination of erlotinib with ramucirumab. Next. So this is the possibly the best and the only slide which summarizes everything. So you can see the first generation TKIs, you had a median, as I told you, PFS of 9 to 12 months. If the patient progressed, depending on T79M mutation, positive or negative, you had an option of using osimertinib versus using a chemotherapy with a immunotherapy or a bevacizumab. So you had about, let's say, 9 to 12 months with the first line, you had about another 8 to 10 months with the second line. So probably you achieved around 20-25 months. What about your third generation TKI? So with the Flora, you achieved about 19 months PFS, and second line you added chemo plus bevacizumab or an immunotherapy, you could achieve anywhere from again 20 to 35 months. What about using first line erlotinib with ramucirumab? So you achieved a median PFS of about 19 months. And if the patient was T79M positive, as would happen, you had an option of using osimertinib. You had a second line in the form of osimertinib, and you had a third line in the form of, again, chemo with an immunotherapy available, probably leading to a better overall PFS or a longer PFS with this combination. Next. So there would be always people arguing in both sides. There are merits to using a third generation TKI. As you can see, I have highlighted both sides of it. So osimertinib, single oral medication, well tolerated, would have CNS efficacy as well. What about erlotinib with the ramucirumab? So again, outcomes are comparable. We have the same median PFS of about 19.4 months. You have a T79M, you could use a osimertinib and then a chemotherapy, immunotherapy in the second and third line, so leading to a more longer PFS in these patients. So it is basically a discussion between the two. Important thing is that if you have a patient with L858, probably even osimertinib would give you a shorter PFS compared to your TKI plus ramucirumab. So you're probably looking at a subset of patients where you should be tackling them a bit differently. Next. Again, highlighting the same fact, if I have to summarize the relay side in relay trial in one slide, you can see the exon 19, the medium PFS in the single agent TKI arm was 12.5 months compared to 19.6 months when ramucirumab was added. And important thing is exon 21. So exon 21, you are looking at poorer survival. So it was about 11.2 months for the erlotinib arm compared to 19.4 months in the ramucirumab with erlotinib arm. So what happened is in both, irrespective of L858 or exon 19, the combination did better, and you had a median PFS of about 19 and a half months, which was probably similar to your third generation TKI, which is osimertinib. Next. So again, highlighting the same thing. Next. So then the question comes. So as I told you, 19, probably you might still opt for your conventional TKIs and osimertinib would be fine. What about 21? So 21, now you need to think hard whether you should be using osimertinib, whether you should be using a erlotinib with a ramucirumab as an option. Next. So again, I had in my initial few slides I had told you. So important thing is you should be knowing, probably more information is confusing, but there is data to suggest that more information about the co-mutations will definitely help you decide on the treatment as well as decide on the prognosis of this patient. So a number of co-mutations are found when we use NGS, and these co-mutations are definitely affecting the response or the PFS of these patients with EGFR mutation. I had shown a slide previously also. Next slide. So co-mutations are found. You can see as I had previously told you, in exon 21 mutations, the number of co-mutations are much higher than in exon 19, but both exon 19 and exon 21 will have co-mutations. And what do these co-mutations do? Next slide. So very well elaborated in this slide. You can see if in a patient who had co-mutation and a patient did not have a co-mutation, you can see the PFS is definitely different. So in a progression-free survival without a co-mutation was 18.7 months compared to just 6 months to a patient who had several co-mutations, and overall survival also made a huge dent. So it was 22 months in a patient without any co-mutation compared to a very meager, it had not reached compared to 22 months in a patient who had multiple co-mutations. So knowing these co-mutations is important. Obviously, you need to know which type of mutations are affecting the overall pathway. I'll give you one example. Next slide. So TP53, which probably we find in most of the NGS panel, even if you don't find anything, TP53, RB, NF1, you probably land up with these mutations in most of your NGS panels. What is interesting in EGFR mutant NSCLC is that TP53 in an EGFR mutated patients, you will see in both at baseline as well as at the time of transformation. And TP53 alterations have been associated with a favorable response to, again, a VEGF inhibitor or a VEGF receptor antagonist, which is your ramucirumab or an anti-angiogenic therapy. So it definitely might prove as a predictive biomarker to a response to anti-angiogenic therapy. Next slide. So again, highlighting the same thing in the relay trial, the prevalence of TP53 mutation at baseline was about 40 to 43%, and at progression was 17 and 50% in both. So exon 19 and exon 21, both cases you had TP53 mutations. And what is heartening is in patients with TP53 mutations, the combination showed a superior PFS compared to your placebo with a TKI erlotinib in both exon 19 and exon 21. So combination of ramucirumab erlotinib definitely showed a consistent benefit in both patients who had TP53 mutations as well as who did not have a TP53 mutation. Probably highlighting the fact that this VEGF pathway is activated in these TP53 mutated cases, and suppressing this pathway is definitely adding to your PFS. So next slide. Again, it's the last slide. So I'll just summarize again that most of the EGFR mutations you can pick up in your NGS, but picking up these co-mutations is important. Secondly, each of these EGFR mutations, so we have not discussing your exon 20 insertions, your exon 18 mutations, because then this lecture would never end. But most of these patients would have to be addressed differently. And there needs to be a thought when you are treating each of these patients. and especially exon 21, which we see quite a lot in our practice. Exon 19 is easy. We are all happy. You have a good PFS in these patients. Probably you need to look harder for your exon 21 guys. Thank you.
Dr. Abhishek, good evening. Thank you so much. That was a wonderful presentation. I think Dr. Rajat is also here. Okay, yes.
Yeah, so I had put up a slide. Osimertinib would do a slightly better in the brain mets guys. So again, it has to be a discussion with the patient, but then you have two options now. Probably you have two combinations, two options. So people might argue on both sides. So you might argue that osimertinib, then I'll give chemo and immunotherapy. Somebody might argue that, as I have argued, that I would like to give a VEGF with a ramucirumab with a TKI first, and then look for T79 and give, then lastly give a chemo immuno, because I want to pull my patients much longer. So I think you can argue both ways. There's no end to that argument. But again, brain mets, probably your osimertinib would score over this combination.
So yeah, exactly. My point is that if we are talking about this combination is an excellent combination. There is no doubt about it. A PFS which is even superior to osimertinib. So what else would you want? But then, and of course, a very important point that you can use osimertinib post this combination so that it improves the overall survival. We all know as medical oncologists that we have to sequence our armamentarium drugs in a way that it increases the OS. But the only issue probably I'll be wary of using this combination is in a patient of brain metastasis,
Yes.
even if it is exon 19, even if it is exon 21, even then brain metastasis, we have hugely gaping curves of osimertinib, and probably that is the only subset. Other subsets, I will definitely want to give this option to my patients.
Yeah, agreed, fully agreed.
Dr. Rajat, I think the specific property of osimertinib, which is the penetration, that is one of the most important thing. The discussion with the patient, whether he wants IV chemotherapy, IV treatment, or simple oral is also very important. Similarly, the presence of L858R, you cannot neglect. Clinical trial shows clearly that osimertinib has less amount of benefit in L858R, and you can see that the subset analysis also shows that Asians, they had less benefit. So I think relay trial is an important treatment aspect, but we cannot downgrade osimertinib because it has got real brain penetration. Real discussion with the patient family regarding the logistics also needs to be kept in mind.
So if you look at all the TKIs available in L858, I think most of them did not do fare well. So they did well, but not as compared to your exon 19. That is one reason which compels you to look into the relay data.
The other issue is OS data. OS data is yet to mature, so that also is a little concerning. Apart from that, there are many positives to this particular combination.
Yes.
Right. I think I thank Dr. Abhishek for again taking us through this very important data set, and thank you very much for being a part of this webinar. Please continue to be with us for the future discussions. So we move
Pleasure.
ahead.